Those names on the left there are your regional directors and their contact information. So please feel free. They are your best resource to reach out to if you ever have any questions, as well as Jennifer or myself. And that is our list of town halls and webinars that we have coming up. We have a medical director open forum next week where it's all led by the members, where you can discuss any of your policies together in a big room. Then we also have on April 20th, another medical town hall, which is the mental, emotional, social health factors and support for children with cancer. And then Dave Malter joins us on April 27th to go over some staff training best practices. So with that shameless plug, I now turn it over to Dr. Kaye Wagner.
Hey everyone, thank you so much for joining us again tonight. We are really excited to have again with us tonight Dr. Dubey from Canada and Dr. Raphael Landovitz from UCLA to talk with us about another COVID-19 update. Hopefully, someone has already said they're hoping for a little more hopeful news, but we'll see what COVID has for us tonight. So Dr. Dubey, I'm going to turn it over to you first this evening.
Okay, great. Hi, everyone, and thanks for having me. Let me just pull up my slide deck. Okay. Oopsie. Okay, there. Are we all good?
Looks good.
Okay. Okay, so thanks everyone. So just a couple of slides, just really focusing on COVID-19 vaccines. I thought that before we start, let's first talk about what we've learned about COVID in the past 2 years. And I think when we really kind of reflect on what we've learned about COVID, we'll be able to actually think about what measures we may need to put in place in different scenarios. So first off, we've learned that for the most part, most people who have gotten COVID are getting it from close contact with someone who is contagious, even if it's for a short amount of time. We used to say 15 minutes. Now it could be a couple of minutes spread out over the day. And so how can we prevent that spread? Well, that's where physical distancing really comes in. And so again, keeping that 6 feet or 2 meter distance, that distance alone will help to prevent the spread. We know that, especially with these new variants, you tend to be most contagious the first few days of symptom onset. And so that's why the message of staying home and isolating if you're sick, and we can talk about what that might mean or look like at camp, and then of course, getting testing. Now, the virus is spread through the respiratory droplets. They come from your mouth and your nose when you breathe, talk, cough, or sneeze, and they can get into the air. So to prevent those droplets, again, wearing that mask will keep your droplets to yourself. It will also protect you from getting other people's droplets. And then washing your hands, covering your cough, that will prevent contamination. And we know that most viruses spread when we touch our face, for example. Now, those tiny droplets, when we talk and we sneeze, can get in the air, and we call those aerosols. And so those tiny aerosols that are in the air, they take longer to reach the ground because they're so tiny. And that's how you get the airborne spread, COVID. And so the way to prevent that is by increasing airflow or by increasing ventilation. And you can do that. That's, you know, the open doors, the open windows, outdoors. And then, of course, we found that it spreads easier when there are more people indoors for a long period of time with poor airflow. So again, avoiding these kinds of settings, indoor crowded areas with poor ventilation will prevent the spread. Now, we know about the new variant. What was called last time as Omicron's cousin, the BA2. I can tell you in our own province, we've seen that at the end of January, just 6% of samples were positive. Now it's closer to 30%. We know that this variant has been found in over 100 countries, so it has spread quite easily. But the early evidence is suggesting that it is quite similar to Omicron. So in terms of disease severity, milder, can be mild in some people, but we know also can be very serious in some people. There is that risk for reinfection. So if you get COVID, if you had it before, you can get reinfected. The good news is that many people who have had Omicron are tending not to get the BA2. That immunity is tending to last. So that is good news, but there certainly have been reports of reinfection. In terms of the vaccine effectiveness, how well does the vaccine work against this variant? It is about the same as with Omicron. And so you can get symptoms even if you're vaccinated, but we know that the vaccines, 1 dose, 2 dose, like 2 doses or 3 or more doses, the booster doses can definitely help prevent a severe illness. But the one change, which is in the wrong direction, is that the BA2 variant tends to be more transmissible. So it spreads even easier than Omicron. Now, the one piece of news, though, that we have to keep in mind is that vaccination, especially those 3rd or booster doses, are the key with these variants to prevent that serious illness, that hospitalization or death. And there is data on vaccine effectiveness of that booster dose that actually shows that if you get the booster dose within 7 days, you can actually have 60% vaccine effectiveness, meaning the vaccine can reduce your risk of actually just getting sick from Omicron and likely also from the subvariant. And the booster will also increase your protection against serious illness. And that's particularly important, I think, when we think about some of the people that you will be serving at camp and others who have chronic health conditions or are older by age. Now, all the vaccines that have been approved for use in Canada, which would be the same as in the US, they have been effective against COVID and all of the variants that we have had so far. So I know people talk about, I'm going to wait for that variant specific booster dose. As far as I know, there's no evidence that that variant specific booster, that Omicron booster dose is going to be coming anytime soon. And there's no reason to wait. The current vaccines that we have, the boosters, will provide that needed protection. Now, I'm just sharing these slides. These are specific to Ontario, which is the province where I live, but they actually just really show visually the impact of the vaccines. And so the orange lines here are people who are unvaccinated, and the blue lines are vaccinated. So if you look on the left, among those who are getting COVID, you can see with this Omicron surge that we had, orange and blue, they're about the same. So even if you're vaccinated or not, you're still as likely to get Omicron. But if you look in the middle section there, if you are unvaccinated, the orange line, you have a much higher risk of being hospitalized compared to the blue line. And even further still, there on the right, being admitted to ICU, your risk is that much higher if you're unvaccinated compared to being vaccinated with at least 2 doses. So just visually showing you why vaccines really are our last standing public health measure in the time that we're at right now. Now, also just a point on long COVID, that it is still real, can be real for children as well too, where they can experience symptoms of feeling really tired, headaches, poor concentration, which can be challenging for children, a chronic cough, for example, as well as in adults. And these long COVID symptoms can occur for weeks, months, even after a recovery. And there may be some early evidence that the vaccines, if you're vaccinated and you get the infection, your risks of getting long COVID are lower. And that data is emerging. Now, just a note, though, that what is in the booster dose, it's the same vaccine as what people are getting for the first to second dose. The difference is the dose. For Pfizer, for 12 and up, it's the 30 microgram dose. First dose, second dose, booster, even second booster. For Moderna, the booster dose is a half a dose for most people, a 50 microgram dose instead of 100 micrograms. But it is the same vaccine. So this is just a visual depiction of what our data in our own city has shown, that with the Omicron surge, the risk of hospitalization increased with age and with not being fully vaccinated. But if you looked at among everyone who was hospitalized, anyone who had 3 doses had the lowest rate of hospitalization, ICU, and death. And that's why that booster dose message is so important as we are now really getting back to life, so to speak. Now, what if someone had COVID in the last 90 days? What is the recommendation there? Well, this is our Canadian National Advisory Committee on Immunization recommends that even if you got COVID, yes, get a booster dose. The studies definitely show that if you got COVID and you get a booster dose, you actually have even better protection than just with COVID or just with the booster dose. That natural immunity that you get from the infection, it is good, but it tends not to last. And that's that piece that I talked about on being reinfected. Now, it's safe to get your booster dose as soon as your symptoms have recovered, but to get the best immune response from that booster dose, you could consider waiting 3 months from your second dose to get the booster dose. So, you know, we're always hopeful with vaccines to try and achieve community immunity or herd immunity. It's not really going to be possible fully, but the goal here, again, is especially with the kind of clientele that you work with, as much as you can block the virus from entering communities, as much as we can do our part to protect those who are most vulnerable, that's really what we're trying to aim for. Now, just a small note to say, yes, still recommend vaccinating children. I know some parents have felt, well, my kid got Omicron, there's no point in getting the vaccine. But the data are still showing that by getting children vaccinated, it reduces the risk of getting very sick and being hospitalized. And we know for most children that risk is low, but it still further reduces it. And I think in particular, it shows that the risk of getting that rare but very serious complication of COVID, that multi-system inflammatory syndrome, that gets reduced by getting vaccinated. And so say for schools, sports, other activities, camps in your situation, mental health, well-being, I mean, these are all benefits for children being vaccinated, as well as the recognition that there's millions and millions of doses of data showing that the vaccines are very safe. Now, right now, there is no recommendation for a third dose in those who are 5 to 11, and that may be coming in the coming months. Now, for those of you up north, north of the US, we do have 2 additional vaccines that have been licensed by Health Canada, Novavax and Medicago. These are non-messenger RNA vaccines. These are what we call protein subunit-like vaccines or virus-like particle vaccines. They're more akin to the vaccines that we use, say, for influenza or for hepatitis, for example. They have just been licensed for adults, though. The Novavax vaccine is going to be available in Canada any day now, really. It is an option for people. Some people we know have been holding out. They just do not want a messenger RNA vaccine, or for people who really could not get a dose of messenger RNA vaccine for rare, but maybe they had a complication related to the vaccine. And Novavax can be given as a booster dose. So just finally, to end off, you know, as we learn to live with COVID, we still need to consider layering our protection and realizing that we still need to take steps, especially depending upon the circumstances we're in. So getting fully vaccinated with that booster dose, keeping a physical distance when possible, especially in indoor settings, wearing that high quality, well-fitted mask where required. I mean, there are certain times when you will be required to wear a mask. Like, for example, if you have symptoms, again, washing our hands, sanitizing, and then staying home if we're sick, for example. And so I won't go through this because it will be very specific to where you are at, but there are certainly times when masks may still be required depending upon where you're at, but also times when masks can be considered. And I think it's, you know, if you live, work, spend time with people who have a weak immune system, or if you yourself are at high risk of getting COVID, those are really circumstances that we need to consider. Okay, and with that, I will turn it back to you, Dr. Kaye.
Thank you very much. Dr. Raphael, we'll have you go through your slides and then we will open it up for questions.
Okay, thank you. That's a tough act to follow, Dr. Dubey. Let's see. Okay, slides would be good. So I'm gonna go a little bit quickly through some of this since Dr. Dubey already covered it. Just a reminder that, you know, we are still in the midst of COVID. And, you know, people always say to me, is it over? Is it over? Is it over? I think we all have colleagues, people, friends that we know are still getting COVID here in the United States. So it's definitely not over. And I think the one thing that we've learned is when you look across the world, this really is a global process. And I think we like to forget that. And when you sort of hear that things are at the lowest point that they've been since last summer here in the United States, we all sigh a little bit of relief. But it's really important to look at what's happening in other parts of the world, because remember, that's just one plane flight away from here. And you know, what is happening in Europe and in Asia soon likely will be happening here. There are, of course, important differences across populations and vaccination levels and, you know, sort of age distributions that make things non-identical, but it is throughout the pandemic been a good preview of what's going to happen here. And right now in Asia and Europe, things are still going quite fiercely. And as Dr. Dubey said, that's largely due to this Omicron BA.2 variant. I'm not going to go into a lot of BA.2 since Dr. Dubey covered it beautifully. You know, it is more transmissible, but not more severe than BA.1. And you can see sort of where deaths are happening all over the world. If you look all the way to the right of this graph that I've shown you multiple times over the time we've had together, you can sort of see, you know, where people are dying right now from COVID. You know, this sort of dark purple, well, I guess not purple, it's sort of, I don't know, what color is that? Magenta, dark magenta? I don't know. Somebody come up with a good name for this color and put it in the chat. So there's not a lot of death right now in the United States, which is great, but that is a little bit of a tenuous hold and distinction right now. So let's just not forget that it is still globally having a tremendous effect on mortality. This is sort of what's happening in the US right now. If you look on the left, you can see what's happening. We seem to be at a very low point, and that's really great. I think everyone, though, is bracing themselves for how long is this lull going to last and what's going to be next. And while this is really reassuring and really great, I would just encourage everybody to not get quite complacent yet. You can similarly see what's happening with hospitalizations and ICU censuses, all of which are coming down and hopefully will continue to come down. So this is hot off the press data for what's happening in the United States. You know, I've shown you multiple times this graph, which is sort of the US analog of the data that Dr. Dubey mentioned for Canada. You know, we've been talking about BA.2, which is this pink distribution. And, you know, since we all last talked, which I think was sometime in January, you know, BA.2 has taken over. And as of today, whoops, hello, in the United States, BA.2 is 55% of our isolates. So I think we're probably a little bit ahead of where Toronto appears to be right now, but we're all heading in that direction where BA.2 is largely replacing the older versions of Omicron in terms of what's circulating. And, you know, at the beginning, Jen and Dr. Kaye said to me, tell me something good. Gosh, I'd love to. But, you know, if you sort of watch sort of what's circulating and what, you know, the WHO and other sort of international organizations are keeping their fingers on the pulse of, this is what the answer is. So guess what? There are 3 additional Omicron subvariants that everyone's keeping their eye on. Nobody knows if these are going to take off and be a problem, but this is sort of the next latest and greatest thing that everybody's watching carefully. So you're like, really? You couldn't come up with, sexier names for these things? XE, really? XD, XF? Yeah, I don't know. Somebody thought this was a good idea, but these are all subvariants of Omicron. And XE, what it is it's a hybrid. It's the love child of Omicron BA1 and Omicron BA2. Now you might think, okay, that doesn't sound so bad, except it's about 10% more contagious than BA2. Awesome. So what does that mean? Well, we need to see, but the thing about this, as we've talked about sort of repeatedly, is it's a foot race, right? It's about which variant is going to outrun the previous variants. So anything that's more transmissible than what's circulating right now at least has the potential to cause another wave. What we don't know is we don't know anything about the severity of the disease this causes. We don't know if it's going to take off. And Dr. Dubey rightly pointed out that we are seeing some people who had BA1 get BA2, although happily it seems to be a fairly rare occurrence and often in people who are not fully vaccinated. We have no idea about XE and if people who had BA1 or BA2 or both can get it. The good news is the more it's just a subvariant of one Greek letter, the more likely there is to be protective immunity from one version of it to the other. Whereas if this were pi or rho or whatever Greek letter is coming next, because I don't know my Greek alphabet, there's more of a possibility that it would be able to escape immunity caused by the previous variants. And so that's sort of what people are most keeping their fingers on the pulse of right now. I will just parenthetically mention XD and XF. We don't know anything about their transmissibility yet, but they're a little bit more scary because they're sort of versions of what you may have heard people refer to as Deltacron. So they're love children of Delta and Omicron. And so we don't know a whole lot about them yet because there's not sort of enough information. But we all know that Delta caused more severe disease than Omicron does. And we know that Omicron is more transmissible. So the fear is that it would have the more transmissibility of Omicron, but the severity of Delta. And that could be a bad thing. And we don't know if this is going to take off. We don't know enough about this yet. But I did want you all to have the up to the minute most information. And Dr. Kaye and Jennifer are going to cut off my Zoom connection and say, we're never inviting you back because you are always the voice of doom. Okay.
Dr. Raphael, where are those other variants being found?
So they're being found in European countries, and they've been found in really low numbers here in the United States. We don't know yet if they're going to take off, but they are beginning to show up more in Denmark, the UK, and other countries in Europe. So I always like to, because, for the US camps, there's a lot of, difference, or there has been in timing of things happening in the US sort of across the country. And, while you might say that New York versus California right now in the US look fairly similar, and I don't want to be, Mr. Doomsday, but if you sort of look at the New York graph and you sort of squint your eyes to the right a little bit, you can sort of convince yourself, are things starting to go back up a little bit in New York? And this is sort of what we've seen historically throughout the pandemic, is the East Coast is a couple of weeks ahead of the West Coast. So everybody is watching this carefully. And as Dr. Dubey mentioned last time, everyone is additionally keeping their fingers on the pulse of the sewage rates of COVID detection in major metropolises and trying to figure out if there are things that are beginning to happen with this BA2 variant in the United States that are going to lead to sort of a shoulder to the level of improvement that we had seen, or a second wave as was seen in large portions of Europe. So I'm not going to go into a lot about the vaccines because Dr. Dubey covered it beautifully. We don't have Novavax or the other protein subunit vaccines in the US yet. It's unclear timing if/ever we will have them. The predominant ones that we have at this point are the mRNA vaccines and the J&J or Janssen vaccine. So these are the United States version of the data that Dr. Dubey showed for Toronto. And the one thing that's broken out a little bit more fully in these CDC data is the light blue line here is people who are fully vaccinated and they got an additional or booster dose. And the dark blue line is people who got fully vaccinated, but they didn't get that booster dose. And the sort of orange, or what would Crayola call it? Burnt umber. Does that sound right? Or am I showing my age because no one would call it burnt umber anymore? Anyway, or no one would use crayons anymore. Okay, but you can see, similarly to the Canadian data, the real difference is people who are unvaccinated versus any kind of vaccination, but the best protection is with people who are fully vaccinated and boosted. And at least the US data for people of different ages is shown on the right side of this slide. People always ask me this, like, how many fold protection do you get if you're vaccinated versus unvaccinated for hospitalization, right? And so I think these are helpful numbers to keep in mind. Hospitalizations are 7 times higher compared to 7 times higher in unvaccinated adults age 18 and up compared to people who are vaccinated. In adolescents, the unvaccinated hospitalization rates are 2.2-fold higher. In age 18 to 49, it's 5 times higher. In adults age 50 to 64, it's 7 times higher. And over 65, it's 9 times higher. So very much parallel to the data that Dr. Dubey showed for Toronto, with a real age-related splay to these differentials in hospitalization based on age. And these are deaths based on vaccination status, which again, you can see these profound differences. The unvaccinated people in black, the primary series only in the dotted light blue, and the fully vaccinated people with the primary series and a booster dose in the dark blue there. So here in the United States, I'm sure everybody's seen, for ages 18 and up, the FDA and the CDC did have an emergency use authorization update, and we'll talk about what the CDC said in a second, that for people age 50 and up or any of the listed immune compromising conditions, you are eligible for a second booster shot. Now, the CDC was very careful in how they worded this. So they have said that it's okay. Dr. Walensky has signed off on this for people ages 50 and up or with these immune compromising conditions, but they stopped short of recommending it. And I think that's really important when we think, how are we going to integrate this into our staff vaccination requirements? And what we've decided to do at Tecumseh is we're going to actually parrot that CDC recommendation. We're going to say that we're recommending it to people who fall into these groups, but we're not going to mandate it, and we're not going to actually track it. And I think that that's a reasonable approach at this point. The data for the second booster is a little bit scant, and I think that's why there's limited enthusiasm. It basically comes from 2 studies of healthcare workers in Israel. And the timing of this second booster shot is a little bit different than the first booster shot. The recommendation is that you get it 4 months after your first booster. And so the same caveat that Dr. Dubey mentioned would apply. If you had actual COVID disease, you would wait at least 90 days after that for the best immunologic benefit, or 4 months after your first booster, whichever is longer. As Dr. Dubey mentioned, you would just certainly not want to show up for any sort of vaccination while you were still symptomatic or during that mandated quarantine period from a COVID infection. And you're probably protected for a good 3 to 4 months thereafter. And that's probably why you don't need to show up for an additional booster at that time. There also is an EUA expansion in the United States for immune compromised children to get a second booster as well. Again, the verbiage is that it's allowed, it's not necessarily recommended. So I think those of you who have pediatric oncology patients, there's probably going to be a lot of discussion about, what the risks and benefits are of second boosters for immune compromised kids. And any of you have any experience with that kind of debate already, I'd love to hear what those discussions are and where people are coming down about that. I'm not going to spend a lot of time on this because I want to make sure we have lots of time for discussion, but we can share these. This is the Israeli data about the fourth dose or second booster. And this was either Pfizer or Moderna that was given in these healthcare workers in Israel. Right, so just to finish up, reiterating what Dr. Dubey said, remember your primary vaccination series should really all be the same vaccine. Your first booster can be with a different vaccine or the same one. I will say that heterologous boosting, meaning going to the opposite one, has been shown in laboratory studies to give you more immunologic benefit, but there's not been shown to be a clinical correlate of that. So in my opinion, if you can get the opposite one as your booster, great, do that. But if you can't, I certainly wouldn't say no to the same one. COVID vaccines can be given anytime in relation to other non-COVID vaccines. You can get flu, you can get meninge, you can get pneumococcus vaccines. All of those can all be given safely at the same time. I completely agree with Dr. Dubey that even if you had clinical COVID disease, you absolutely should get the booster or boosters. It is absolutely true that immunity from both getting a vaccine and having had the disease is actually the best immunity. The problem, of course, is a lot of anti-vaxxers are saying, aha, we knew that all along. I'm not going to get the vaccine, and there, herd immunity, natural immunity is the best. Incorrect. The best immunity is from having both. The risk, of course, of getting COVID before you're vaccinated is obviously this multiple factor increased risk of hospitalization and death. So honestly, it's a game of Russian roulette, and why would you play it? I think, many of us get frustrated that we were good worker bees and we got our vaccinations, and many of us got COVID anyway. And it's not because you did anything wrong, it's because of these highly transmissible variants. Just think of yourself as super immunized now, and hopefully you'll be more protected should something more hideous and obnoxious come along in the next wave. So just thank your immune system and thank your vaccinations that it wasn't more severe, and hopefully none of you had a super severe case. And if you did, I'm really sorry. So we talked about the timing of that booster. And so what does this mean for Camp 22? And, I don't know, when we talked in January, I told you my crystal ball was cloudy. It's still cloudy. I don't know. At Camp Tecumseh, we're planning in-person camp. We are planning for the worst, but hoping for the best. And Dennis and others on the call can give additional details. But we're watching very carefully test positivity rates, the community transmission levels, in northern New England, hospital occupancy, and we are geared up to do rapid PCR testing of every camper and every staff member before they arrive on campus, before we let them in. And follow up rapid antigen testing at multiple time points during the week. And we are going to be potting and cohorting, and we're not going to have visitors. So that's what we're doing. We hope it's overkill. We'll see. Anybody who goes into camp season with a different approach, we would love to hear how it goes. And I'll stop there. And thanks for your attention.
Thank you very much. So we're going to open it up to questions. Jen has listed several in the chat, so I'm going to let us get started. So the first, she said, how does a past positive diagnosis of COVID impact testing in camp? Meaning, does the type of variant they tested positive for in the past have an effect on their false negative or positive rate for camp testing?
It shouldn't. I'm not aware of any data that indicates that it would. We do know, I think I showed you data last time, that the rapid antigen tests are less sensitive for the Omicron variant, particularly in the first 2 to 3 days of illness, but it only does test for active disease. It shouldn't affect any testing. And Dr. Dubey, I don't know if you have any other experience or insights about that.
Yeah, no, I agree with that. In using the rapid antigen test, you're less likely to get a false positive, but you could have false negatives, right? But then the PCR testing, we know previously with previous variants or previous COVID, it could sometimes linger and give you what we called a recurrent positive, even though it wasn't a new positive within 3 months. So I think, but if you do testing when someone has symptoms and you get a positive, regardless of whether it's PCR or rapid antigen, you have to consider it's a new infection, because reinfection can occur.
I think the other point is, we don't talk about this often because a lot of labs don't report it, but there's this thing called a cycle threshold when you do a PCR that is sort of the opposite of the amount of virus that the PCR test detects. And so the higher the cycle threshold number, the lower the amount of virus. I know that's counterintuitive, but just think that it's Alice in Wonderland backwards. And most people would generally say above about a cycle threshold of 29 to 30, it's very unlikely to be an active, real, or transmissible infection. So PCRs, although they get reported as yes or no, there's actually a little bit more gray area to it that you can use to help if you were to get a low positive, someone who had COVID illness in the not too distant past. Little known facts.
And I think that maybe is what you guys have addressed, but how does the timing of their positive diagnosis impact the test result at camp? So meaning if it's less than 30 days since they got over COVID, will that affect the results when they come to camp?
I mean, the majority, no. The majority of people will have turned, they'll certainly be antigen negative. They'll likely be PCR negative. If they do come back PCR positive, you would say, what's the cycle threshold? And if they're asymptomatic and that far out, unless they themselves are immune compromised, I would ignore that.
All right. What are your requirements for vaccinations at camp?
Is that a question to us at Tecumseh?
Yes, I think to both of you.
Okay. Dr. Dubey, do you want to talk about the camp that you're involved with first?
Yeah, I mean, I think the vaccination question, we used to have vaccine mandates here. A lot of places have taken them off, mostly because they were 2-dose vaccine mandates, and recognizing with Omicron that, you really need to strive for that booster dose if you want to try and prevent infection, and also because of that waning immunity piece. So I still think, though, that the message is, even if you were to have a 2-dose mandate, it will still ensure that if someone were to come to camp and get infected, they're less likely to end up in hospital. And so even having a 2-dose mandate with a recommendation for a booster dose, especially if they're eligible, is something that I think is very reasonable. A mandate for a booster dose is another way to go. I know that people have different levels of, how much they want to mandate things, but I think at least having the basic of the 2 doses is still something that I would strive for.
At Tecumseh, we don't have any problem being mandators. We're mandating that all staff be fully vaccinated and boosted, and all campers be fully vaccinated based on what they are eligible to receive. And if that includes a booster, then that's required as well.
Okay. Beverly, I'm not sure I completely understand your question. Do you want to unmute and ask it?
So the CDC guidelines right now for infection are to quarantine for 5 days, I think after onset of symptoms, and then 5 days wearing an N95 mask. I recently had Omicron, and I'm involved in a U of A hero study and tested daily with a PCR. I was positive for 10 days. So part of me was like, wow, those guidelines are pretty minimal. So how long after an infection would you allow somebody to staff, volunteer, or attend camp?
I think some of that has to do with whether they themselves are immune compromised. If they're not, I would not want somebody on camp property until 10 days. I'd love to hear Dr. Dubey's thought on
10
that.
days following.
So the problem is a lot of these are asymptomatic, right? So I would say 10 days after either the first test or onset of symptoms, whichever is later.
Yeah, I think what you have to really decide is your camp, because it's for medically fragile or immune compromised individuals, you have to consider it like a healthcare setting. And when you do that, the 10 days becomes really what you strive for. And I know here, there are staff shortages. And so at day 7, you can, if you have 2 negative rapid antigens, you can return, but of course, always fully masked. I think the other piece you have to ask is, if you get them back to work at day 5, as you know, they can still shed for that 5 days, which is why the recommendation is to wear a mask in public settings. Will staff be able to adhere to that at camp? And if they don't, you have to recognize then they could be spreading to very vulnerable individuals.
And then just the only thing I would add to that, I completely agree, is remember that, especially if you're doing an overnight camp and it's a closed setting, right, then that person is ostensibly going to be bunking with others, and they're not going to have that mask on 24/7. And is that something that you want sort of interacting with other people that in your camp setting?
Actually, can I just build on that, Dr. Rafi? So what is your plant policy for when someone gets symptoms on camp? Because I think that's one that it's really hard for me to wrap. Do you send them home? Do you test them? If they're negative, 2 tests, 48 hours, like what are you doing?
Well, I think it depends what the symptoms are. And I think we're going to have to make that on a case-by-case basis. We're still honestly talking about that, but our medical team is trying to figure out, right, really, if there's any question, shouldn't you just send someone home and not risk it? And, I think, if somebody is having any symptom that could be consistent with COVID, do we have the capability to do a PCR as the most sensitive test in that moment if they're symptomatic? And if it's positive, then the answer is pretty clear. If they're negative, I think we're going to have to, still go on a case-by-case basis. But I think it's going to become progressively challenging, the further you go into a camp program, because people are going to be exhausted and tired, and perhaps living or sleeping in conditions that may have allergens that may cause runny nose or cough, and it's going to be hard. And I'd be making things up if I told you I knew for sure what the right answer is.
Okay, a couple more questions. Would anyone, excuse me, would anyone on the call not do camp this year if you could not require vaccinations? I know that's a challenge for our friends in Montana who are not allowed to mandate. Looks like that one people haven't made up their mind on yet, Jennifer. A clarification, did we find out or did we clarify if the type of test matters? Is anyone doing PCR pre-camp and antigen upon arrival still? That's what I was planning to do. I don't know what others are planning for their testing.
Sorry, Dr. Kaye, I missed it because I had to go deal with my Great Dane who was having a spaz event. What are you doing at your camp?
There was a question to clarify if the testing matters and if anyone's going to be doing PCR pre-camp and antigen upon arrival. That's what we were planning to do at Bring It On.
I mean, if anybody is interested in doing this, we We are set up, we're getting set up. We are set up, Dennis, I think it's arrived. We're using the Abbott ID Now PCR machine to do rapid PCRs on all staff and campers upon arrival. And you can do that on a mid-turbinate nasal swab. It's not as expensive as the CDC recommended PCR, but it's more expensive than rapid antigen testing. I think it comes out to about $40 per test.
So you're
Am I
just
getting
doing
that
that
right,
on you're doing that on arrival and not requiring the prior test?
Right.
Okay. And what was that called again? I'm sorry.
It's the Abbott ID Now point of care PCR test.
At the camp that I was at last summer, we had that on site. And it's actually helpful to consider, because if you end up in a situation where we actually used it for symptomatic people. So when someone had symptoms, right, and you had like as you say, in the middle of camp now, everyone has a runny nose. I think at one point we had, like whatever, 30 people. So we had a tent where they would wait. It's rapid, but you can only do one cartridge at a time, and it takes 10 to 15 minutes. So it's still, you can get the results same day within hours or minutes, depending upon what the lineup is. And so that is, so there are, I do have to say, I think that was a game changer when you're really trying to not sure about the symptoms, and recognizing you really can't rely on the rapid antigen the day symptoms start.
So getting the machine and everything, the cost ended up being about $40 a test. Is that what you're?
Yeah, so fascinatingly, the Abbott company, I'm trying to remember the details. If you buy 300 tests, they will rent you a machine free. So there is no cost to the machine. 312 tests, Dennis, thank you. So we're doing that, and we're borrowing a second machine from another local lab. The one thing you do have to know if you do set that up is they will not sell to you or rent to you if you don't have a CLIA waived lab license for your camp location. Now, that's not hard to do. It's a pretty simple application if you have someone who's willing to take on that role as medical director. And then there's like some nominal fee, I can't remember, Dennis, $180, something like that, for the license. And Abbott will not sell to you unless you do that.
That is amazing. Thank you. That was actually one of my worries, as I was trying to figure out, because my plan was to do PCR pre-arrival and then antigen when they get there. But the funding, depending on if the public health emergency continues, is hugely variable, and we cannot afford it if we lose that act. And so that's really helpful. Thank you.
Look into that. We were really pleasantly surprised that it seems to be like it's going to work out.
Yeah, Rafi, you were right. It was $180 for the CLIA waiver process. But please keep in mind, 312 tests is just over $12,000. So that it is still a costly venture, even to do that. You still have to pay, I think it was $41 per test. So 312 tests is over $12,000. So just so people know that, but it's cheaper than a $200 typical PCR test.
I was going to say the last bid I got was $75,000 to test our whole camp. And I'm like, well, that's not happening today.
Yep, that's what we were seeing too. And we said, forget those bids. We're not doing that.
So Susie, an ID Now can only run one test at a time per machine, and it takes 13 to 15 minutes. So that's why we're borrowing a second machine, because you can imagine arrival day is going to need to be a carefully orchestrated ballet to test everybody in that time frame upon arrival and have them wait for their result before they enter camp property. So that's our operational nightmare of the hour.
We're tackling the same thing. I'm trying to figure out how I hold people up and not have them backed up on a main road coming into camp to get this sorted out. So
If you figure it out, let us know, Dr. Kaye.
I will do my best.
It's going to be like moving kids into the dorms on a college campus. It's going to take us a couple of days.
Yeah. We talked about trying to do, scatter arrival times, but we all know how well that's going to work with people following the rules on when to show up. Susie said that they used a local high school in the area. So tested before they got to the campsite. That's a great idea as well. Other questions that people have?
We had great, our parents were great last year at following their assigned times. So they each we brought them in by their cohorts, and they were given an assigned time. I don't think we had, maybe a few campers arrive early, but otherwise they were all pretty close within their 15-minute time frame, and they registered. It was drive-through. They never got out of the car. Registration. They went on to screening station, went on to the testing station, and while we were doing a rapid antigen at the time, we did the medical check-in at the car while the testing was actually processing. So, and I got nurses from the local APON chapter that were not participating in camp that was their philanthropy. So I didn't have the medical staff that were going to be there all week tied up doing testing. They were actually available to talk with the campers and kind of do that check-in. It worked really smoothly. Then once they approved, they got a little card for their window. They drove on and got their lanyard, went up to campus, and were directed to their housing location. Again, never got out of the car the whole time. Parents stayed in the car, kid got dropped off, went with the counselor. It worked great.
Looks like Jamie is saying they had pretty good success as well with testing away from the entry gate. And then by the time they got there, their test was able to be resulted. Parents followed the times quite well. So that's great to hear.
That's an interesting idea.
Other people that did this last year have tips that want to share or other questions?
I have both. So last year we did staggered times and our parents followed it perfectly. It's about the only thing they followed 100% perfectly, but that's another thing that we'll never go back and we'll do forever. Second, so I'm looking at the vaccination rates for 5 to 11-year-olds, and it looks like nationwide fully vaccinated is about 27%. Do we expect that to be lower or higher for children with cancer? And I'm wondering if anyone who is requiring vaccination this year is seeing a decrease in enrollment so far like we are.
I could comment. We actually opened our summer camp apps on Friday afternoon, and we have 56 people have enrolled. 4 of those reported not being vaccinated, but one of those had scheduled their vaccination. I talked to one of our long-term follow-up clinic NPs at one of our hospitals today about something, and she said that she's finding that people are now requesting vaccination because they want to come to camp. So, and then we've been tracking what I'm calling our vaccine hesitancy. So we've had about, since we first let families know in like November that COVID vaccine plus booster would be required at camp, I've been tracking, and these are only the people who have come forward to ask for, are we going to give exemptions or whatever. I'm tracking about a dozen families, and that's across all of our programs. The comment on the younger kids, we have a day camp coming up, and we were really thinking that the kids would not be vaccinated in that age group. We've actually had a higher response this year for a number of campers in that age group than we did in 2019. And out of the, let's see, I think there's 27 kids that have applied for either the virtual day, both days, or the in-person day. Only 3 campers in that 5 to 10 year age group are not vaccinated, and one isn't 5 yet. She'll be 5 in time enough to get vaccinated before camp. So we were really surprised at that.
Looks like the Good Times Project has had a decrease in enrollment for campers and staff. They are requiring vaccines and recommending boosters for everyone. But then Kelsey's camp, they're doing their second day camp. They've had higher numbers than in 2019 with no objections. We have seen a bit of a decrease in our numbers, Ryan. I don't know if that will pick up or not. It's a little bit early for our campers to get themselves registered. So, but we've seen a few parents that have not been happy with the vaccine requirements. I did lose a couple of staff members as well because of the vaccine requirement. Looks like Julianne's camp, they had 16 families that they had to turn away because of vaccines. So they've had a forceful decrease. That's a good description.
Can I ask a question?
Of course.
Just one, this is a clarification. I think we talked about it before, but I just wanted to verify that the old issue about people with peg asparaginase allergies is no longer an issue with the mRNA vaccines, right? I'm asking our doc friends here.
Yeah, that's generally true. Occasionally you will find somebody with clear pegylated multiple things, allergies, and you
Yeah.
probably want to pay attention to that. But my understanding, and the pediatric oncology folks on this call probably have way more experience than I do. But my understanding is it's okay. Dr. Kaye, is that your understanding also?
So I've been following the report out of, I think it was Toronto Sick Kids. If they can tolerate Miralax, I've been giving the vaccine, but I do watch them for 30 minutes instead of 15. And I've been successfully able to do that.
Okay. So if you had a child that had the severe reactions and they weren't able to get, since the mRNA is the only thing that's available to them, would you exclude them then? And I mean, they're kind of high enough risk. I don't know if their oncologist would let them go anyways, but how would you treat that if they applied for camp?
They're
I
probably
just
the
feel
ones
like
that-
every kid that I screen has a peg asparaginase allergy. So
well, and like I said, I've been, even the people with severe peg asparaginase allergies, if they've tolerated Miralax, I've tried the
Okay.
vaccines.
great.
If they
Okay.
don't know, then I've not. But if they've got a truly documented medical reason why they can't have the vaccine, I'd probably be encouraging Evusheld or something like that.
Oh, yeah.
They're
good
still on
idea.
treatment, some other way around. If
Yeah.
they're not eligible for something like those, it's not their fault. So I'd maybe be willing to consider that one exemption, but it would make me a little bit nervous to do it. It's
Yeah.
my approach.
Nope, that's good. And I forgot about Evusheld, so thank you.
Other docs, have you had that question or have you decided how you're going to approach that?
You know what, we have special immunization clinics that you can often refer people to as well, that are run by allergists. So, anyways, just thinking about how they can consult, because regardless of whether it's camp or not, if they actually can get the vaccine safely, it's really something in their best interest as well too. So that's another consideration, special allergy clinic to get assessed as well.
We're actually willing to give a medical exemption if it's a true medical reason. For instance, a true allergy to polyethylene glycol, or they reacted to the vaccine. I did have somebody today sent me an exemption form that was signed by the pediatrician that said due to their toxic chemotherapy, they had a 1-year exemption from it due to the risk of pericarditis. It was in a 10-year-old male. And the pericarditis, first of all, is rare and has been seen more in those adolescents. So I did require that they seek the exemption from their oncologist who knew their treatment plan. And actually, what they're seeing more is that these kids that are at risk for cardiotoxicity, I think that are getting COVID, are being seen in the cardiology clinic because of the cardiac toxic effects from the COVID and not from the vaccine itself. And so I think sending them back to their long-term follow-up survivorship team for that education, I think, is important.
Susie, I can't emphasize how much I agree with that. I mean, I think people who are looking for a reason to not give the vaccine will glom onto this myocarditis, pericarditis issue, completely forgetting that the incidence of myocarditis or pericarditis, if you get COVID, is astronomically higher than it is
Right.
from the vaccine to start with. So it's so penny wise and pound foolish. It's a personal sort of major frustration of mine.
It's a hard place for all of us who are responding to these kids, though, because, you know, these families reach out and they're devastated and they're disappointed. And how can you force kids to get vaccines? I mean, these are some of the emails that you get, and you just try to continue to reinforce that you have to support the safety of everybody at camp, and that it's recommended by CDC, AAP, and, you know, all the other organizations, but it's the only way you can provide that safe environment. And we've decided to keep our virtual arm going. And so I just really encourage them to look at that if they feel that they are not comfortable proceeding with the vaccine. But you do feel like the bad guy a little bit.
Other questions? All right, well, thank you to both of our presenters. We really appreciate your time and everyone joining us tonight. This will be available in the outside the box along with the chat for questions that have been